Hello friends, I'll be talking about a case of stent migration in coarctation of aorta and its management. As we all know that stent migration has always been a a thing which has always erred us whenever we are on the table. Whenever we do a coarctation stenting, we have to ensure that every single patient is a textbook in itself. It teaches for itself. Like for example, this particular case was a 60-year-old female. She was resident of Nepal and she had a persistent hypertension diagnosed for last 10 years. She has been a geology professor. She was doing excellently well, except for repeated headaches, which she used to have. So, incidentally, she was diagnosed to have uh, hypertension, and subsequently, a good clinical sense prevailed, and they found the femoral pulses are not very good. And so, a clinical suspicion of coarctation was supported by the echocardiography, which showed that LVH is significant, and they underwent a CT angio. Look at this SETI, and it's a case of severe coarctation. There is a proximal segment which is there. There is a narrow segment which is a bit tortuous, and distal there in a different plane. Looking closely, I have drawn the proximal segment and I have drawn the distal segment. And clearly, the proximal segment and the distal segments are in alignment. They are actually in a very different plane. The proximal and the distal segments are in a very different plane. So she had a total arch gradient of 70 millimeters with diastolic spill. There was no associated anomalies like patent ductus arteriosus, like VSD. Her aortic valve was although bicuspid, but rest there was no anomaly. It's always good idea whenever evaluating a coarctation to look for the associated anomalies. If there is a patent ductus arteriosus, if there is a VSD, hemodynamically they can cause a problem in assessing the gradients. So also the arch dimensions, which are very important. Although whenever we are doing a CT scan, we have to measure the arch dimension, but always make it a point to measure the arch dimensions, particularly the transverse arch, the descending aorta at the level of the diaphragm, and the ischemic diaphragm. Of course, she had a left ventricular hypertrophy also. So the question is, what if we do nothing? She is 60 years old. She has some hypertension. Every grown-up has almost an hypertension, and except for that, occasional headaches. But practically, there are no other symptoms. What if we do nothing? So let us discuss the outcome of unoperated patients of tetralogy. If we see this particular pie chart, it is very clear that many of them are going to have congestive heart failure. Many of them are going to have aortic ruptures, bacterial endocarditis, intracranial hemorrhages. So it is very clear that if we don't intervene, definitely she is going to land up in a state of intracranial hypertension. We are going to accelerate that particular process. The interpretation is definitely we need to do something about this. What are the available options? The available options include surgery, balloon angioplasty, and stenting. Surgical is always a very bad option for a grown-up patient. The reason being, as it was evident in this particular case, there were a lot of collaterals. As the surgeon goes from the side, there is likelihood of bleeding, which happens a lot, and also a proximal segment which needs to be clamped, this distal segment which needs to be clamped, causing lot of secondary complications. So the complications from surgery include paraplegia, of course, serious complications like death, recurrent and residual coarctations, the hypertension, dissecting aneurysm, stroke, coronary artery disease, which coarctation itself gets exaggerated. So my clinic has surely shown that clearly shown that the survival is almost 91% if you diagnose for next 10 years, 84% for 20 years, and 76% for next 30 years. So definitely something needs to be done, and surgery is not a good idea. Coming to balloon angioplasty, yes, balloon angioplasty has shown significant results with a very good outcome, but our case was a slightly torturous thing, and the best option with a good transverse arch and a descending aorta in this particular case would have been stenting. So it was decided to undertake a coarctation stenting for this particular case. The usual preparations, bolus dose of heparin was given 100 units per kg. We have to maintain an ACT of 200 to 250 whenever we are doing all these procedures. preferably all the excess needs to be pre-planned, and preferably should be taken by ultrasound guidance, because we will be taking a very big sheath through the arterial excess. We'll be taking 12 French or 14 French. We'll be increasing it to 12 and 14 French for the stents. So definitely it should always be taken through ultrasound guidance. And so was taken in this particular case. We had planned for a right femoral artery, 8 French, and a left brachial artery, which a 5 French was taken because it was a tortuous arch, and there is always a possibility that we may not be able to cross it. To cross it, an end-over multi-purpose catheter with a straight thermo was used, and gradients were taken. A hemodynamic assessment was done with upper limb pressures of 240 and lower limb of 60, showing a significant gradient. As clearly it is evident that how echo was underestimating the gradient in this particular case. We took the patient on the CAT table, and there you see injection. Luckily, we could easily cross from the descending aorta, and ascending aorta shows a dilated ascending aorta. Support wire of O35 support wire was parked into the ascending aorta. And there you see an injection which is done in the proximal segment using a marker pigtail, showing a severe discrete coarctation of aorta. And what is also evident in this particular case, as you see in an LAO 30-degree view, the first angiogram, that there is definitely a malalignment between the proximal and the distal segment. When do I call it a malalignment? I draw a straight line onto my junction here, and I draw another straight line from the descending aorta onto this junction, and I would see that they will form clearly an angle. They would not be in a straight line. So whenever forming this, the concept of malalignment is very, very recent. Concept of malalignment is rarely identified, but should always be seen proactively for all these cases. We could easily cross it with a 12 French sheath. The length of the stent was chosen as 45, considering there was a malalignment element which was there. For a malaligned element, it's always a good idea, because as the segment is going to expand, it is likely that we have to account for the malalignment which is there. And since there is a malalignment, there is a possibility that this stent itself is going to foreshorten, and that is why there is a possibility of its migration. So we had taken a 45 millimeter length, and which is mounted on a 20 into 5 bib balloon. So there you see that proximal injection has been done, is being given by the sheath, and the stent position looks fairly away from the subclavian and in a reasonably good position. We took another injection. The stent has been withdrawn gradually, and the other, as you gradually withdraw the stent and take these injections through the side port, you can clearly see that as the stent is being weighed, the stent position looks pretty comfortable. Always it is a good idea to take a complementary view. So because of this malalignment, you can clearly see this difference. This is LAO view where the stent looks in a perfectly normal position. But look at the RAO view. In RAO 30-degree view, the stent is essentially, most of it seems to be in the proximal part towards the ascending aorta, towards the transverse arch, and only distal part has very minuscule thing which is there. So it was decided to readjust the stent. Again, angiogram is done where distal segment is pretty good, and then a gradual expansion of the stent is done. But lo and behold, what has happened? The proximal stent is hardly inflating, and the distal stent has significantly inflated. So probably our position is not appropriate. We need to readjust the stent. So a partially expanded stent is being profiled in the same LAO view and is being tried to park in the proximal segment. And you see the RAO view there. It is clear that my stent is definitely lying more proximal, and there is hardly any stent in the distal part. So what is the next step which we need to do? This is mounted over a bib balloon, luckily. And if it's over big balloon, at present the inflation has taken off the inner balloon. So 10 millimeter inner balloon, which has inflated it partially, is being tried to pull the partially inflated stent with the partially inflated stent proximally. But as the attempt is being done for the same, it is being tried to pull into the segment. There you see it, the stent has migrated. What has happened is, as the 10 millimeter stent was being pulled proximally by the inflated inner balloon, the partially inner balloon just pulled through the proximal segment, and there is no balloon over. The stent is just over the wire now. It is lying in the proximal segment, and but luckily it is over the wire. So what are the available options at this particular moment? There is a stent which has migrated proximally. There is a wire which is across it, and the balloon is much more distal to it. So the first attempt is, of course, to re-intubate the stent. But as the attempt is made to re-intubate the stent, it tends to push the stent more proximal. So because it's a partially inflated balloon, so a partially inflated balloon was taken out, and there you see a stent which is dancing there, dancing nicely, telling us that, giving us a challenge as to what we need to do next. We tried with a new balloon, took out the dilated balloon. There you see a new balloon which is being attempt is made to part a new balloon across this, but that particular balloon is also getting slipped. It is actually not holding on. So the main problem is that there is nothing which is actually holding on to the there is the balloon, the assembly. We need to actually, the stent needs to be stabilized before we can actually intubate the balloon. The available options, had it been a distal migration, was that we could easily have deployed the segment, the stent in the distal segment, reinflated it, and deployed the other stent through it in the proximal segment. That would have made the job easier. But this particular migration is in the proximal segment. And if you find the case reports, there has not significant case reports about this. The available options include one Dr. Cannon's publication, which what they did was actually snared the whole assembly and then reintubated it. The problem of snare was that yes, we need to have a bigger access, and but the ultimate aim is also, the snare can actually, what I feel, could distort the stent in itself. The other option is, of course, to deploy the stent there and deploy additional stents, hoping that it would not jail any of the side branches. But this being in a proximal segment, very close to the origin of the carotids and the subclavian, there is a possibility that the proximal segments can easily get jailed. So we thought that we will go with a bioptome. So what is being done is, there you see a bioptome which has been introduced. This is a 5 French bioptome, 140 centimeter, which has been introduced through the proximal 14 French sheath. How this bioptome has helped is, this is transiently, this has stabilized the stent. Once it has stabilized the stent, the intubation had become easier with the balloon. So once we have stabilized the stent was intubated with a 10 millimeter Z-med balloon and inflated. And once it was inflated over the balloon, we could easily redeploy it over a 10 millimeter balloon and pull it at the approximate position, like you see in this particular video. We could bring it much more proximally, inject and re-expand it. So once it was re-expanded to a 10 millimeters, it was further, another bib balloon would expand it to the requisite 20 millimeter, which was there. And this shows the final inflation with the 20 millimeter balloon. Clearly, the proximal segment, which is marked by the pigtail catheter in the proximal segment, as there is a sparing of the pigtail, which is there, a sparing of the pigtail, that means sparing of the subclavian, which is there. And there is this angiogram which shows that the angiogram, because it's always a problem with grown-up 60-year-old patients. When you take an angiogram in the ascending aorta, because the dye always falls short of also there is a bicuspid aortic valve. Since it's a bicuspid aortic valve, the dilatation of proximal dilatation is always big. So this next particular angiogram, we are trying to inflate the proximal segment just to have a proper positioning so that it is much more stable in its usual position. And there you see an injection through the sheath, clearly demonstrating the stent is very well deployed and there is no gelling of the side branches. This is same thing which we have discussed, an injection beginning in the ascending aorta in the proximal segment. The proximal segment being a 60-year-old with a bicuspid aortic valve with a dilated aortic root, the dye was always falling short. So ultimately, injection through the pigtail, through the sheath was much more diagnostic, showing the stent was appropriately placed. This is the echogram which shows that the stent is in situ with a very good laminar flow across the stented site. Now, the coarctation of aorta stents is definitely a full growth of the segment is achieved when the patient is more than 9 years or 25 kgs. So a case of recurrent coarctations, a native coarctations who achieve this age, or a coarctation which is associated with aneurysm or dissection, one should always consider for a stenting. And all these settings, it is always good idea to go for a covered stent. The success is almost 100% because there are complete abolition of gradients as was seen in our case, and restenosis is always less with a coarctation stent in the coarctation stent in situ. For our case, we had taken, and it is true for any coarctation segment we want to do, these are the places where measurements are to be done. It has to be done in the transverse arch, it has to be done the ischemic diameter, it is to be done at the descending aorta. Remember, the segment just beyond the narrowing is already dilated. So post-stenotic dilatation, if you have to measure and size the stent, we are always going to overestimate the stent size. So it is always a good idea to measure it much more distal at the transverse arch, at the descending aorta, at the level of the diaphragm. And it is the maximum diameter which has to be taken in systole to decide for the diameter of the stent. The balloon size is always has to be 2 to 2.5 times the narrowest segment, and one has not to exceed the size of the isthmus or the descending aorta. Post-procedure hypertension is very common with all these things because of the resetting of the baroreceptors. So one might have to continue giving drugs like metoprolol for some time for control of hypertension. Clearly, there is established method now for any of these patients. Multiple case reports all across the world have clearly shown that coarctation stenting is accepted modality, particularly for adolescents and adults. Whenever it's a long segment coarctation, it's a isthmic hypoplasia, a tortuous arch, or a residual gradient after angioplasty, it is always a good idea to go for a covered stent. I would add to it what we have been re-emphasizing right from the first slide, that a concept of malalignment. One must always look at the proximal and the distal segments, see if both the segments are malaligned. Because whenever we are deploying a stent in a malaligned segment, you can yourself think that the proximal and the distal segment, the stent is going to lie in a very, very abnormal configuration, and there is a possibility that can easily slip. Like in our particular case, most of the stent look perfectly well if I was looking at a LO position. When I took a contralateral, uh, RO position, I could clearly see that my stent was not appropriately placed. And this was essentially because of the malalignment. So it's always a good idea to have at least two views, maybe LO and RO, two complementary views to decide before you really deploy the stent. And if you really feel there is a significant malalignment, always increase the length of the length of the stent. In our we have taken a 45, which is a pretty long segment. But could we have taken a longer stent? Well, we had a 60, which is a custom-made stent over our shelf. But we decided to go for 45 because it was pretty discreet thing, not a very long thing. But still, we face this migration because of the malalignment. Stent migration is very rare complication seen in generally 5% of the patients. It is generally because of the under or oversized balloons, and mostly it is treated in cath labs. Balloon rupture is one of the complications which can also lead to this particular event. Whenever it's a distal segment, the management is clear. You deploy the stent, take another stent and deploy it proximally. But the problem is always proximal with so many important arch branches going to the cerebral circulation to the hand that you don't really want to deploy the stent there. So what are the other factors? Like this particular case, which I've taken, is management of stent in coarctoplasty with 3 overlapping nitinol stents. So what they ended up was, to ensure that the stent has migrated, they actually deployed stent within stent and deployed 3 stents to make a casing and ensure that the stents hold on. Many of the case reports talk of surgical treatment for this particular migration. If it's a proximal segment which is migrated, always go for surgical and retrieve the stent. This was the case where I was talking, where a stent which was actually a snare was used to redeploy the stent. It's a very good method. The problem is snaring it to this with holding it in such a way that you might actually distort the stent is always a problem, particularly with a covered stent. The other important thing, what we had used was actually a bioptome. The problem with a bioptome is that bioptome has to go with a very is to go almost hug the wall. So there is always a risk of injury which can happen whenever you use a bioptome. So what is the precaution when you are using a bioptome for deploying a stent is, you take the sheath right this as distal as possible so that your bioptome does not really hug the wall, so that it stays away from the wall which is raw. So we ensured that the sheath was very proximal so that our bioptome can easily get manipulated and it can hold on. We just have to use the bioptome translate enough to help it intubate the stent. Never try a bioptome to hold it in such a way that it can pull and redeploy the stent, because that wouldn't be possible. It will keep on slipping. The bioptome, the aim is just to hold it so that you can reintubate it with the appropriate size balloon and then bring it to the appropriate area. So this particular case highlights the concept of malalignment between the proximal and the distal segments. As we see a patient of coarctation and decide what we have to do, we must always look at this malalignment, because this itself can cause problems, as was done in this particular case. If there is a malalignment, it's always a good idea to use longer balloon or maybe a longer stent that can help to tide over this. And a bioptome can facilitate the intubation of the stent for deployment in the appropriate place, because and never try to use a bioptome to pull the stent, because you will end up causing more damages. I thank you, and I thank the LifeTech for giving this opportunity to present this case. And it will be, I'll be happy to answer any queries which can be directly sent to me or emailed to me. Thank you.